Good morning to everyone and welcome to the third day of our webinar series on WHO Clinical Perspectives on COVID-19. With me, my name is Dr. Albert Domingo from the WHO Country Office in the Philippines. And with me are my colleagues, Drs. Gary Kuniyoshi, Sophie Dennis, and James Heffelfinger to deliver another of our webinar sessions, this time on antimicrobial therapy. Dr. Sophie Dennis will be the one speaking for this morning. And as she will mention, we cannot overemphasize that SARS-CoV-2, or the virus which is causing COVID-19, does not yet have a proven antimicrobial. So the discussion here, as Sophie will tell us later, is not so much on treating SARS-CoV-2 itself, but the other possible co-infections happening with the patient. So let's get into the matter, and I'm passing it on over to Sophie. Go ahead, Sophie.
Thank you very much, Albert. Thanks for the introduction. I'm just going to share the PowerPoint now. So great to see so many of you here. It's nice to have you here this morning. As Albert's already said, and I think it is very important, and I'm sorry if I sound like I'm repeating myself, but it will be the case that what we're going to cover does not cover any specific COVID-19 therapies. So we'll be looking at the broader picture of patients that come in with symptoms suggestive of severe pneumonia or sepsis. So at the end of this lecture, you will be able to prescribe empirical antimicrobial therapy to patients with severe acute respiratory infection and or suspected severe pneumonia and sepsis. Describe antiviral therapies for influenza infection, note influenza infection, so we will cover that. And then describe current therapy frameworks for the COVID-19 infections. So we'll look at how we can robustly create clinical trials to try and find a therapy for COVID-19, and also look at compassionate frameworks as well. We'll cover very briefly corticosteroids and viral pneumonia, and then overview at the end. So what antimicrobials can be given for patients with SARI? So as covered yesterday by Dr. Gary, we're looking at patients who are presenting very unwell. We need to take an ABCD approach, and we covered on Monday oxygen therapy, and yesterday in terms of inotropic and support from that side of things. So in patients with sepsis and septic shock, you need to give antimicrobials within 1 hour of recognition, and we know that delaying this can have very adverse results and can affect mortality as well. As bacterial pathogens often coexist with viruses, and when a patient first presents, there are no current diagnostic tests which are accurate enough or fast enough to determine whether the presentation with the severe pneumonia is due solely to a virus at the time of the presentation. Our recommendation is to initiate empirical treatment for bacterial infection or co-infection. So, talking about what empirical antimicrobial therapies there are, what you're wanting to do is target those pathogens that are most likely. So when we're talking about respiratory infections, it can be divided for those which are community-acquired or hospital-acquired. So the most common pathogens include Streptococcus pneumoniae, Haemophilus influenzae, Moraxella catarrhalis. So really you're wanting to base these antibiotics on the local epidemiology, susceptibility and resistance data, and then your national and local treatment guidance. And this won't change from unless there's been recent change in your local guidance, but this will be your routine patient who presents with severe respiratory symptoms. So I'm not at this stage going to provide you with what we would give as guidance, because it really is specific to your hospital, to your where you are working and practicing. When we do give antibiotics, you're wanting to look at the patient and rationalize what is the most appropriate antibiotic. So if you know that they have chronic kidney disease, If you know that they have hepatic impairment as well, you may want to dose adjust or use different antibiotics according to that. Other patient factors to consider are whether they're at risk of opportunistic infection, so whether they are immunocompromised, whether they've had chemotherapy in the past, or organ transplant, or may have co-infection with HIV, and whether they're known or at risk of resistance to antibiotics, and we'll come on to that shortly. So once you know what pathogen you want to target, and when choosing the correct antibiotic or antimicrobial, you need to ensure that that antibiotic that you choose can penetrate into the tissue, presumed to be the source, so in this case, into the lung tissue. So antimicrobials such as aminoglycosides, gentamicin, might not be appropriate. So patient presents, they're clinically very unwell, they're suggesting and showing signs both clinically and radiologically and biochemically suggestive of a severe community-acquired pneumonia. So this is patients coming from the community. We would suggest using a combination therapy of beta-lactam and then an antibiotic against the atypical pneumonias. So a macrolide or an alternative to macrolide, including doxycycline. This shouldn't be given to those who may be pregnant, or an option would be one of the respiratory quinolones such as levofloxacin. Though I know that in some places, if there is endemic or high rates of tuberculosis, they may want to avoid this. So as I discussed in the last one, if your patient presents and they are known to be immunosuppressed, you might want to consider anti-pneumocystis treatment as well. And if you have a high endemic population of community-acquired MRSA, you may want to add in vancomycin and linezolid. So these are just thoughts that every patient who comes in, you're providing individualized therapies that you can rationalize. And when prescribing antibiotics, you want to ensure that you have a review date on which to next review it. And usually when you are just starting the medicine, we would suggest even after the first dose or after 24, 48 hours to review this. And we'll come on to why this is important when considering de-escalation and ongoing management. So antibiotic regimens for hospital-acquired pneumonias. You raise suspicion for patients who have had IV antibiotics within the last 90 days. These are usually broad spectrum antibiotics that can increase the risk of multi-drug resistant pathogens, whether they've been admitted from a nursing home, whether they've been actually admitted from another healthcare facility, or if they've actually been in hospital for a couple of days, so over 48 hours, and develop symptoms suggestive of a pneumonia, then that's when you would consider additional cover and a change in the antibiotics that you would prescribe. So you're wanting anti-pseudomonal cover, cephalosporins, so either third generation such as ceftazidime or fourth generation cefepime have anti-pseudomonal activity, and then carbapenems or other agents that are described below, so beta-lactamase inhibitors, fluoroquinolones, or aminoglycosides. But as we discussed, aminoglycosides may not be an appropriate option, but to be considered. Adding in anti-MRSA if they're at high risk of mortality and or the need for ventilatory support due to the pneumonia and sepsis. So this would include vancomycin and linezolid, or vancomycin or linezolid. So coming back to, you've prescribed the antibiotics, hopefully after some time, and you're clinically reviewing the patient regularly, the patient is improving. You want to be reassessing and always have at the back of your mind when it would be appropriate to de-escalate, and you want to have that preemptive plan in place. The aim is to narrow down your spectrum of antibiotics once you establish a causative agent. And this is ideally when the patient first presents, you're within your sepsis bundle, wanting to take samples, microbial samples, to see whether you can isolate what the pathogen is. So that will be blood cultures if they present with sepsis or severe pneumonia. You want to be taking sputum samples, and we'll come on to slightly later, but viral swabs and other viral PCRs or respiratory PCR panels to have a look to see if you can find what organism that may be. That being said, it should be noted that if you do find a pathogen, it does not rule out co-infection. So you must base all your clinical acumen on how the patient is in front of you, how they are responding to the treatment, and tailor it according to that. So in the absence of clinical or microbiological indications of bacterial infection, you can consider discontinuation of antibiotics. And I think this is something that us clinicians and as a team find difficult to do, because we want to, of course, give treatment when we can, but it does need to be considered. So continuing with that, often and more often than not, you may not find a causative agent, and it makes de-escalation difficult. There is no strict criteria for that de-escalation protocol, but you need to consider how the patient is doing clinically. So are they showing signs that they are improving? Is their shock resolving? Signs that the infection is resolving. So you're looking at inflammatory markers, biochemical markers such as procalcitonin or C-reactive protein, to ensure that these are downtrending over the course of a couple of days. WHO recommends that antibiotics should be given for 5 to 10 days of duration to treat the most severe infections associated with sepsis, including chest-related sepsis. But again, this has to be taken in the bigger picture, in the context of how the patient is responding. 5 days is usually enough, but if they are found to have certain infections, so if they have a Staph aureus bacteremia, then of course a 5-day course is not going to be adequate. So it really needs to be taken on a case-by-case basis. So we're now going to look at reasons for clinical deterioration, or despite giving antibiotics, antimicrobials, why the patient is not improving. So is it the wrong antimicrobial treatment? Is there drug resistance? Is the pathogen just not responding to the antimicrobial that's being given? Or is the potency of the antimicrobial regime not enough? Is it not reaching and penetrating the tissue? Or are there actual host factors as to why the antimicrobial isn't reaching therapeutic levels? In the top right, it describes complications. So is there a lack of source control? And let me reiterate, these are with if there is co-infection of a bacterial infection, so sepsis driven by a bacterial infection, so an empyema, a lung abscess or necrotizing infection may happen, and that's why if they are not improving, you may consider repeating a chest X-ray or ensuring at least that you thoroughly re-review the patient. Metastatic infection, again, this doesn't relate specifically to COVID-19 or viral infections, but the bacterial aspect of it may penetrate into the CSF, may cause endocarditis, osteomyelitis, or septic arthritis. And then also, we were discussing if a patient has been in hospital for a little while, if they have invasive lines, they're more likely to have other infections, and if they've been having antibiotics as well. So really just need to keep a close eye out if there's any clinical change. So could you have entirely the wrong diagnosis? And of course, if it's not due to bacteria, then antimicrobials will not be effective against it. Is it a non-infectious pneumonia? Could the patient be presenting with cough, shortness of breath, and hypoxia, which is due to a pulmonary embolism? Could they have cardiogenic edema? Could it be pneumothorax, drug fever, or malignancy? These should all be considered, and this is not an exhaustive list of other presentations. So keep that at the back of your mind. And finally, patient risk factors. So we discussed briefly, are they immunocompromised? May they have HIV, cancers that are affecting their ability to fight the infection, chemotherapy recipient, and do they just have a process in which they're not able to mount an appropriate immune response? Do they have an underlying disease that impairs healing, such as diabetes? So yes, we want to start antibiotics, antimicrobial therapy when anyone presents with severe respiratory symptoms suggestive of a chest sepsis or pneumonia. You really want to rationalize what antibiotics you start depending on the patient, the individual patient in front of you, but also in keeping with the local guidance that you have it at your institution. You want to ensure that you start them early. Giving appropriate antibiotics minimizes the risk of superinfection, drug resistance, adverse effects, and cost. And if you're concerned about a drug-resistant pathogen, or as described, that you're not quite sure why the patient isn't improving as they should do, then getting input from the infectious disease team, a senior, or the clinical microbiologist, if you have one, is definitely the next step or worth considering. So that's covering antibiotic therapy for those patients who present. It may be presenting with COVID-19, or it may just be a community or hospital-acquired pneumonia. Next, we move on to antiviral therapy. So I must reiterate, there is no known effective antivirals for COVID-19. The data that, and what I'm going to explain next is antiviral therapy in those with influenza or suspected influenza. So when it is suspected, you want to be starting an antiviral as soon as possible. Early initiation, as with the antibiotics, is associated with improved outcomes. That being said, just because you haven't started it initially doesn't mean that you shouldn't give it if the suspicion is raised at a later date. So you can give it at any stage of the active disease when there is ongoing viral replication. So what antiviral agents are available for influenza? The neuraminidase inhibitors, so oseltamivir, and you may well know it from its trade name, Tamiflu or Antiflu, is probably the most well-known. There are other IV agents of the same class of drugs, so that's zanamivir or peramivir, but what I'm going to focus on is the oseltamivir. So the WHO recommends for patients with severe or at least or at risk for severe seasonal influenza. I repeat, influenza. So this is not relating to COVID-19. This is just looking at the data available for influenza and other zoonotic influenza virus infections. And it can be given as a tablet form or as a liquid form. So it can be given if a patient is intubated and ventilated. It can be given via an NG tube. Dose is 75 milligrams twice a day for 5 days. This is adjusted if the patient has renal impairment and a creatinine clearance of between 10 to 30 milliliters per minute. That's reduced to 75 milligrams once a day. So interpretation of the test results. I mentioned briefly that the patient comes in, you're wanting to take swabs and samples to see whether you can isolate what the pathogen is that is causing the patient to have their clinical instability, their sepsis, and what's driving it. But it must be noted that tests themselves need to be taken within the clinical picture. You can't rely on them, and either starting or stopping treatment needs to be taken within the clinical picture. So interpretation of the test results. Detection of the virus depends on multiple factors. So the timing of the sample collection from illness onset, and we know that recent data has suggested that actually the time of highest viral shedding may well be 2 to 5 days prior to starting to have symptoms. The source of the specimen, so whether you're taking an upper respiratory tract specimen or whether you're taking a lower respiratory tract infection, so you'll get more capture from the lower respiratory tract infection if you're managing to do a bronchial lavage. The type of virus, the diagnostic testing assay, storage and transportation conditions, and then the host factors. So a negative result needs to be taken in the clinical context and considered carefully. So just to recap this on antivirals for COVID-19, there are no effective antivirals. There are current candidates which are being potentially evaluated by clinical trials, and I will come on to that in a little bit. But first, what I'd like to focus on is the use of compassionate medicines in the context of COVID-19. So the use of unregistered or unproven therapeutics needs to be strictly monitored and with ethical approval. So what do I mean by that? So we can use the Murie Framework. So the Murie Framework is monitoring emergency use of unregistered and experimental interventions, so known as Murie. So it's essentially ethically allowing patients to be offered experimental interventions on an emergency basis outside of clinical trials, but you must be able to fulfill the criteria below. So there has to be no proven treatment that exists. So that is the case for COVID-19. That you're not possible to initiate clinical studies immediately, and if this isn't feasible, then it's to be considered. Animal or lab studies need to support the efficacy and safety of it, and there needs to be scientific rationale behind picking that particular medicine. So it must first be recommended by a scientific advisory committee. It then needs to go through an approval process by the country and these ethical authorities. There must be adequate resources available. Importantly, you need to have informed consent from the patient. So it's necessary that the patient is made aware that the intervention may not benefit them and may even harm them. The ultimate choice of whether to receive the unproven intervention must rest with the patient. They can't be coerced into making that decision. If the patient is incapacitated, so they're unconscious, they have cognitive impairment, or are too sick to understand the information, you may get proxy consent obtained from a family member or from an authorized decision maker. And finally, monitoring and data sharing with the wider community. So the physician overseeing the Murie process has the same moral obligation to collect all scientific relevant data on the safety and efficacy of the intervention as researchers overseeing a clinical trial. So moving on to a clinical trial, and this is something that the WHO has been working on and released back in the middle of March, is the Solidarity trial. So it's in order to fast track research on repurposing existing drugs. It's a large international clinical trial to help find an effective treatment for COVID-19 that may slow disease progression or improve survival. So to begin with, the Solidarity trial compares standard of care with 4 treatment options based on evidence from laboratory, animal, and clinical testing. So those medicines include remdesivir, lopinavir in combination with ritonavir, lopinavir and ritonavir in combination then with interferon beta-1a, or chloroquine or hydroxychloroquine. So the trial has actually started in a couple of countries already, in Norway, Spain, Iran, and Switzerland, and there are 95 countries that have expressed an interest. So hopefully we will be able to get a lot of data quickly and find a robust answer to the clinical question at hand. Within our region, so within the Western Pacific, Philippines, Singapore, and Malaysia are currently in the ethical approval process. So this will be something that will be relevant to yourselves, hopefully soon. And we won't cover it too much, but if you do have questions more about this, then I'd be interested to hear. It should be noted that the process is relatively simple. You don't have to collect too much patient information, so it's not too heavy on the clinicians themselves, and it shouldn't be a barrier to using the clinical trial. It's all done online. There's no additional paperwork, so it really is there to facilitate being used. And finally, I just wanted to end on the use of corticosteroids and viral pneumonia. So I know Dr. Gary covered this yesterday when he was looking into the sepsis part of management of patients who present with suspected or proven COVID-19. And so I'm just going to cover from the viral pneumonia side of things, so different side of things. Corticosteroids are associated with various negative clinical outcomes, so prolonged viral replication. And by this we mean there is the chance that there is increased viral shedding of the coronavirus in the respiratory tract when corticosteroids are used. So that's of course a reason not to use it, because it can increase transmission. It can also cause avascular necrosis, hyperglycemia, psychosis, and increased mortality. So has to be considered very carefully. It is known and can be used already in indications such as exacerbations of asthma, chronic obstructive pulmonary disease, refractory shock. So that covers the basis of what Dr. Gary was speaking about yesterday, or co-infections with PCP. So I should say severe PCP that meets criteria. WHO says there is no proven role for corticosteroids, just in the fact that someone is presenting with acute influenza pneumonia or one of the coronavirus infections from data from previously with those epidemics in the past. So the take-home message really at this stage, and I'm sorry if I sound like I'm repeating myself, but there are no known antiviral therapies for COVID-19 infection. All therapeutics should be given under strict monitoring and ethical approval, preferably the randomized control trial. And I'm pleased that the Philippines is going ahead so strongly with the Solidarity trial. So hopefully that will be enrolled in the foreseeable. If influenza virus infection or bacterial pneumonia is suspected, then treat SARI patients with empirical antimicrobials for all likely pathogens as soon as possible. And in patients also with sepsis, administer effective intravenous antimicrobials dependent on your local or national guidance within 1 hour of recognition. So these slides have been created, and we are thankful for those within the WHO committee who have created these. And just want to end, so we're currently on our 3rd day of a 5-day webinar series, and tomorrow Dr. Gary will be covering respiratory failure and ARDS. So I'd like to hand back over to Dr. Albert to mediate the questions, if that's all right. Over to you, Albert.
Thank you, Sophie. So just again, we cannot overemphasize, we always repeat, there are no antivirals yet for SARS-CoV-2 or the virus that is causing COVID-19. But we are looking at, we just heard from Dr. Sophie, a discussion lecture on how to treat co-infections. So we're looking at influenza, bacterial pneumonia, and sepsis, among other possibilities. So we have right now 356 participants, around 220 on Zoom, with the rest on YouTube. For those who would like to ask questions, if you are on Zoom, the best way is to look somewhere down there. There's a button somewhere there that says Q&A. You can click on it and it will bring up this interface where you can type your question. You can read other questions from other participants, and if you think that they have already asked it, just click the thumbs up sign, which will upvote the question and allow me as moderator to see that question ahead of the others. For those on YouTube, we are still monitoring also the live chat, so feel free to chat in your questions and we'll get to answering them. Let's begin with a question from John Michael Bernardo. Any thoughts on the potential use of ivermectin for COVID-19 patients, or even hydroxychloroquine rather?
I haven't heard anything about ivermectin myself. Maybe Dr. Gary or Dr. Sophie have. But hydroxychloroquine, I mean, is one of the medications that's being looked at in the Solidarity trial, and I think the jury is out right now. There are a number of institutions that are using it, mostly I think under research purposes, and I think that's probably the best way to do it. But the jury is out on what the efficacy of that medication is. But I'll defer to Dr. Geary and Dr. Sophie also.
Thanks, James. No, I haven't heard of the use of ivermectin either. And as James has just said, the hydroxychloroquine is within the Solidarity trial. So there's no data as of yet for its use in COVID-19 or its efficacy, but we will have to wait and see. Over.
All right. From Dr. Limuel Abrojena of ASMPH, have there been studies on the culture of organisms obtained from patients that present with mild COVID-19 and patients with severe COVID-19? Have you come across any of those? What organisms are being found?
Can I just clarify? Is that looking at then co-infections alongside COVID-19?
That's right.
So my understanding from the WHO, there's no data yet that's been published that I'm aware of that has looked into this. I'm sure it's definitely an area of interest, whether that sort of what co-infections do exist, but not to my understanding. Thank you.
Right. So before I go to the next question, that's probably a good suggestion to our practicing clinicians out there. We're not about to recommend that please do cultures, but if it is part of your management that you are ordering cultures, then perhaps you could work with your hospital administration to gather the data, and maybe we can have like Philippine-based data. Next question from Jed Quintanar. Would you recommend administering the influenza vaccine to the community in order to prevent them from getting any complications with this if they do get COVID anytime in the future?
Yeah, maybe I'll take this one, and then Dr. Sophie or Dr. Kuniyoshi can come in. So in Philippines, and specifically, there are a number of risk groups that are targeted for influenza vaccination, and I think those include the elderly. I think I can't remember exactly which risk groups, but I know that the national policy is to vaccinate elderly, persons with comorbidities, and I think it may be also pregnant women and possibly healthcare workers. I think it would be important to for your policy to probably fit in with what Philippines national policy is for that, but that's my understanding of Philippines policy towards seasonal influenza vaccination.
Any comments on further comments?
I think nothing else to add other than we haven't been able to see any association of co-infections between influenza and COVID-19 yet. So they almost have to be seen as different entities. And whilst giving the influenza vaccine for those high-risk populations may prevent them from getting influenza, it doesn't suggest that it prevents them from getting COVID-19, or we know it won't prevent them from getting COVID-19 or any of the sort of to affect the severity of it. Thanks.
Right. Donna is asking, is there already a guideline when is the best time to collect samples for an accurate result for diagnosis? For example, is there like a guideline on the number of days upon exposure to the infection or upon symptom onset when you can gather samples?
Is this specifically for COVID or is this for co-infections?
The question doesn't mention, but I think it's safe to assume that it's for COVID.
Yeah. Gary, do you want to take that? One thing I will say is that many countries have particular recommendations they have testing algorithms, and Philippines in particular, actually, I'd say Dr. Albert probably has the best understanding of the Philippines algorithm from his work with DOH and the country office. But I think that, yeah, I mean, it's a great question. I don't know. I can't say specifically when the most, the best time to test is, but there is some suggestion that people that viremia starts increasing, and maybe even a day or two before symptom onset. So, but I think I'll defer to the other physicians on this panel.
Yes, thanks, James. So I think there is new emerging evidence, as you say, that suggests that the viral shedding may be highest earlier on in the onset of the illness, so a couple of days before. I'm not sure whether the WHO has yet released the guidance exactly when, but when we're talking about a patient that presents to hospital with severe pneumonia or sepsis, then we wouldn't defer, or we would suggest when they come to the healthcare facility, that's when you would take the swab. Over.
So the guidance on testing, it very much reflects what stage that you're at. So if you're at the stage, if your country's at the stage where you have cases versus having clusters versus community-wide transmission, the testing strategy does change. And the guidance generally leaves it to the local to decide when the appropriate time to do testing is.
Right, just a quick comment, and thanks James for referencing the Philippine guidelines. So the DOH at present is using an algorithm that really depends on symptom presentation. So the question, which is originally like, when is the best time to collect a sample, might sound like more applicable if we do get to a stage where there is like more testing for asymptomatics. But at present, like we always catch patients when they're already at least mildly symptomatic, but mostly already in the severe stages. So probably like as James already mentioned, like there are studies showing 2 days before symptom onset. So when we do catch them, it's already like probably on the 3rd or the 4th day after the virus has started increasing its load. All right, there are quite a number of and very good questions on solidarity. Let's start first with a seemingly easy to answer. When do we expect to see preliminary results from the solidarity trial?
Hard to say. I'll take that one. So I know that from data that's already being collected, they're looking and quite as you should do with any clinical trial, looking at any side effects that have been associated. So we've had some preliminary data from that side of things. It will take more time and the more people that enroll in it to produce an overview of what's going on so far. The advantage is that any data input into the solidarity trial is centralized and concurrently and continually evaluated. So if there are any emerging trends of efficacy, then hopefully we should get an idea sooner rather than later. But I can't put a time frame on that, I'm afraid.
Right. What if a patient has already been taking hydroxychloroquine because he or she has lupus or rheumatoid arthritis? Will this probably affect the clinical course?
I don't know what the exclusion criteria is, but it may well be that they won't be included in the trial for that reason.
Right.
Yeah, and I think it's hard to say. I think it would be hard to say what, I mean, if there were enough patients, it might be, well, one, I would say if you're taking it for a medical reason and there's a clear indication, then they should continue taking it. And at some point, if there are enough people who are taking it, there may be enough data to look at whether such persons had any kind of protective effect of it, I guess.
So the next two questions are still on the solidarity trial, and they are related to each other. First one is, how are the drugs or the intervention arms included in the solidarity trial determined? So why those 4 combinations or 4 kinds of drugs? And what's the rationale behind giving those? That's the first question. I mean, set of questions rather. The second question is, how about the antiviral favipiravir or Avigan from Japan, which is not part of the solidarity trial? So do we have any knowledge on that? So why the 4 intervention arms, and why is favipiravir not part of it? Over.
Shall I start? So in terms of rationalizing the 4 medicines that they initially chose, it goes through a very rigorous process. So it's not just that they've been sort of randomly picked. The first medicine, so remdesivir, was actually first created. It's not licensed for anything, but was first looked at for the Ebola virus. And since then, within other coronavirus epidemics, so the MERS, and SARS, they were shown to have some benefit in both animal testing and also in vitro testing. So they didn't proceed to doing sort of human clinical trials with that medicine. So that's why they saw the rationale that it may well be beneficial for its use in this trial. So it seems to be one of the 4 medicines to be considered. I also know that when they were looking at the process as to what medicines to include, there was quite a lot of external pressure from the hydroxychloroquine and chloroquine side of things, that these medicines were actually already being used, whether in trials or compassionately. So the WHO thought it necessary to include it in the trial to sort of try and create this robust evidence from that side of things. Over.
All right. Still on the drugs inside Solidarity, should we, I'm assuming that Dr. Chi is probably asking, assuming that a patient is enrolled, should we start hydroxychloroquine at the onset of symptoms of pneumonia in COVID-19 patients? Or should we start it with azithromycin and hydroxychloroquine as a combination? Okay, maybe she's not referring to Solidarity, but you can answer in general. Because she saw it in data from other countries that they use the antivirals once the patient fulfills the sepsis criteria. So when is the best time to, based on evidence or guidelines, if any?
I don't think there's any data yet on that. I think maybe that's one of the things that Solidarity trial will answer. I think the one concern I would have with starting hydroxychloroquine or the combination hydroxychloroquine and azithromycin right off the bat, there's a fair amount of screening that you might want to do prior to this. You know, one of which is concerns with azithromycin and probably hydroxychloroquine in persons who are on other medications, and what interactions there might be if they have cardiac, any kind of cardiac illnesses or conditions, particularly prolonged QTC intervals. You can end up doing more damage than good. So I think the jury's out, and my understanding is azithromycin is not part of the Solidarity trial. So I think the answer is still, you know, with combination with that medication, I think Solidarity, at least as conceived so far, will not answer this question, but I'd like to hear what Sophie says.
Yeah, no, I agree with you there, James. Azithromycin isn't part of the Solidarity trial, but I have heard that it's being used in combination, hopefully either within other clinical trials, because there are other clinical trials other than the Solidarity that are going on. So hopefully they're collecting data, and if they are doing so and they get enough, then we may be able to hear what the outcome is from that. Over.
All right, still on the subject of antivirals and would-be treatments. So remember, every one of us here on the panel have been reminding everyone that there is no proven and documented treatment yet. And I'm saying that because the next question is saying, there's a current movement in the Philippines trying to push for the Fabunan antiviral injection. They're claiming, its proponents claim that it has already been approved in the US. Does WHO have any statement on this? Several lay people are spreading videos about this antiviral. So we are picking it up at the country office level, and no, it's not part of the Solidarity trial. And the FDA of the Philippines has already released a press statement as of April 8th saying that the two products are not registered. And of course, not being registered, they still have to go through evaluation, just like any other drug or therapy proposing an effect. So no, there is no position on it. We're waiting for it, should it be applied for any approvals, but no, it's not a part of the regimen. And then the next question would be, let's see here, in a primary care or community setting wherein testing for influenza is not available, for which patients would it be advisable to prescribe oseltamivir empirically?
So I'm going to answer just from the influenza side of things. So this isn't COVID related. If you're just asking from the influenza side of things, those that it can be prescribed for mild influenza symptoms are those that are high risk. So categories would be the elderly, those that are pregnant, those who are immunosuppressed or have chronic conditions that are within that criteria. Sorry. In terms of in the community, there is a large basis on the need to do this sort of clinically. So if they have severe symptoms, then that may well be another indication to give the oseltamivir within the community, or at least to escalate to sort of secondary or tertiary care. Over.
All right, zooming out a bit from the solidarity trials to more general topics. JV Tamayo is asking, in reference to the mention of a daily assessment for de-escalation, is there guidance on the minimum number of days to give a certain antimicrobial before shifting or de-escalating? For example, do we shift after at least 3 days if there is no clinical improvement? So when do we shift?
That's a very difficult question, and there is no one answer to that question. It really does have to be dependent on the patient, their parameters, their biochemical markers, radiological changes, as a host, how susceptible they are, whether there is that early need to escalate antibiotics. I think they also mentioned about de-escalation as well. De-escalation from a sort of an antimicrobial stewardship is something that clinicians do find very difficult, because you may have started a treatment, the patient may be clinically improving, and it's very difficult to ascertain whether it's because of the therapy that you're giving. If there is a clear indication that the source of infection may well be coming from some other source, then you need to target that instead. But it really needs to be done on a case-by-case basis. If you have concerns and wanting to rationalize it, then getting one of the infectious disease specialists or a senior involved may well be the right next step. Over.
All right, JM Labao is asking, are there any alternatives for antivirals when the patients are suspected to have viral pneumonia, but it's not available, like in low resource areas or in the community settings? So not necessarily infected with COVID. So alternative therapies.
I'll answer that one. So to my understanding, not that the WHO would recommend, I guess it's again looking at the bigger picture, whether there could be co-infection. So whether antibiotics might be appropriate in that situation if you can't prove that it is a viral pneumonia, or there may well be a co-infection, but a difficult one, I'm afraid. Over.
Right. So next question, COVID-19 patients may require mechanical intubation for prolonged periods of time, especially since early intubation is currently recommended or is an option, as it may be difficult to distinguish between viral and bacterial pneumonia. Is it recommended to give empiric antibiotics for the entire period that the patient is intubated?
No, so we wouldn't recommend giving antibiotics for the whole duration. Again, based on clinical improvements, hopefully you would still stick to the sort of desired time. It may be extended to 14 days, but 10 to 14 days, but we wouldn't recommend using prolonged antibiotics. You should always have a review date, and just being intubated is not a reason to continue antibiotics. Over.
Right. Another question, may I also suggest if we could look into the co-infection of dengue and COVID-19. We've been hearing of cases of pediatric patients initially being tested positive for dengue and then later on positive also for COVID. What's your take on that? Over.
Yeah, well, the one thing I had heard was that at least with some testing, there may be some cross-reactivity in that it may have been an incorrect dengue test or inaccurate dengue test, or it could have been a positive dengue and then then a false positive COVID. So I think that's one thing that you have to consider. A big concern is dengue infection, and I think in the next few months we'll be coming into, I think, a heavy dengue season in the Philippines, and anyone who has a fever suspect COVID at this point by themselves, by their neighbors, by physicians, by everyone else. And I think really resolving that is a question. I don't know about how much cross-reactivity there is. I think if you have the two infections concurrently, it would seem that it might make things more serious, but I don't know if there's any data. And I would love to hear what Dr. Geary and Dr. Sophie have to say on this.
Nothing more to say really on that, James, other than yes, if the incidence is picking up, then you can't just always be considering COVID-19. If dengue is prevalent, then you need to take the whole picture into consideration.
Right, and just a quick comment from a health systems perspective, it's going to be a challenge because, as James did mention, when the sun goes down, so to speak, and the rains come in, dengue will spike, and it's the same health system we're looking at. And we know that COVID is going to stay for at least a few more months. So yeah, it's a challenging thing to look at. Hazel Dokuyanan is asking, can you share with us your thoughts on the use of tocilizumab for COVID patients to prevent cytokine storm? This drug has been used for COVID, but may we know why was it not included in the Solidarity trial?
So yes, it has been sort of in the sphere of whether it has any effect on COVID-19 and improved outcomes. Theoretically, as a monoclonal antibody, I believe against IL-6, correct me if I'm wrong, it should, if this cytokine storm, which we know can occur in patients with severe COVID-19, whether it has some effect, but it hasn't been included into the trial. The Solidarity trial can add in other medicines sort of later on. It's not a completely fixed thing. So if they do think at a later stage there is enough rationale and basis to include it in the study, they will do so. Over.
Right. Carmela Barcelona is asking, what are the dosing regimens, dosage strength, duration, etc., for each investigational drug or drug combination being considered in the Solidarity trial? Do we have more information on that? And are there specific data or guidance for COVID-19 treatment in that regard?
So if you can look up the Solidarity trial on the WHO website, and it, to my understanding, does give dosing. In terms of duration, I know for remdesivir, there have been a couple of trials outside of the Solidarity trial, which obviously hasn't produced any data, so that looks at either 5 to 10 days worth of treatment. But I think from the Solidarity trial, you can look on the website for that. Over.
Right. Another question, aside from clinical parameters, can we use non-specific markers like CRP or procalcitonin for those on antibiotics to guide us with the treatment?
This is an age-old question. So I think this goes back to if you, regardless of COVID-19, if you have a patient that you think has a bacterial pneumonia, what markers you can use. The biochemical markers can complement clinical findings, but the number one thing is reviewing the patient clinically to assess how they are improving. Over.
Right. July Mirandilia is asking, and I'm also asking because I'm joining her question, do we already have data on COVID-19 and tuberculosis co-infection? How do we expect the coexistence of each other? My additional question is, we've been seeing reports supposedly of BCG vaccination being protective, allegedly. What's our take on that, or what do we know so far?
Okay, from the BCG side of things, they're currently carrying out some trials in the Netherlands and Australia, some large trials from that side of things. But the WHO has released a statement saying that there is no associated benefit of having the BCG and COVID-19. So there is nothing to suggest that it is protective of COVID-19 at this stage. Again, things can be revised, but that's the current statement. Sorry, Albert, what was the other question? Was relating to tuberculosis and COVID-19. To my understanding, it's too early. There hasn't been any data yet released or nothing that the WHO can support with regards to the association between the two. Over.
Right, and a quick note on that. This is another area where the Philippines may actually take a lead given our tuberculosis burden. We do anticipate that there will be a lot of co-infections, and we would urge our clinicians to go through the proper ways of documenting and submitting and publishing the data. So another question, this one is a quick one. Kathy is saying, thank you for a very informative lecture. Though COVID infection is more common in adults, are we going to have a separate lecture webinar for pediatric patients? Like this antimicrobial therapy for pediatric patients with a COVID infection. Can we just give them a preview? Do we have any plans on that?
So no plans within this series of webinars. I will just say the question says that COVID-19 is more common in adults. That may not be the case. It's just that they exhibit the symptoms. Children may have either very mild or don't exhibit any symptoms. But with regards to sort of targeted lecture, looking at the pediatric side of things, I don't think that will be in the scope of what we're able to provide, unfortunately. Over.
So don't worry, Kathy and colleagues, maybe for this week, not yet, but definitely we'll hear your suggestion and we'll discuss how we can probably work something out. Another question.
Sorry, Albert, sorry to interrupt. Just to say, if you do look at the SARI toolkit, so that's the SARI toolkit, it does actually at least say the dosing for pediatrics and does have a look at triaging, and there is a pediatric section on that. So it doesn't specifically look at COVID-19, but there is a section there. So it is well worth having a look.
Okay, a little more on the vaccines. Where are we now in the development of vaccines for COVID-19?
Well, I'll start. And at least as of last week, and it could have changed, it likely would change, but there were, I think, 64 vaccines and that were under development, or at least that's what, at least 64 that were under development. And I think 3 that were at least in clinical phase 1 clinical trials. So I think that's where we're at. Actually, Dr. Gary may know if additional ones have gone into clinical trials. I still will be months before they get to phase 2 and finish phase 3 trials, and at that point there's still regulatory issues and then scaling up production if an effective and safe vaccine is found. Over.
So I think my understanding, 67 that were in early stages. Then I think there were 2 or 3 that were in stage 2, and then there is 1 that's actually entered stage 3. So it's progressing along. But as James says, just because a vaccine has entered sort of stage 3 trial stages means that we're getting there, but it's still a long journey. Over.
All right, a specific question. With the co-infection of multi-drug resistant A. baumannii with COVID-19, is there a recommendation for antimicrobial therapy other than sulbactams? So I guess if this is related to usually hospital-acquired infections with the Acinetobacter, you would just treat it as you would
as per your hospital guidance. I don't think there would be any change to guidance as to what antimicrobials to use. Over, Gary.
Yeah, the guidance is going to say use your local guidelines, and if you don't have local guidelines, then you can use other guidelines such as Infectious Disease Society of America or British Thoracic Society. They also have specific guidelines on use of antimicrobials for multi-drug resistant.
And the other thing I would say is that if it's highly resistant, then looking at what the susceptibility panel is, I don't know if there are isolates that are just susceptible to cephalus or to trimethoprim sulfur or sulfonamides, but you would really want the susceptibility panel to guide what your treatment regimen would be.
Right. A quick specific question, but I think it's also important. For patients with HIV/AIDS, can they still be given antiretrovirals when they are positive for COVID-19?
So yes, we would never suggest stopping any antiviral medicines for HIV because it increases the chance of resistance and can have drastic consequences later on down the line. So we would never suggest that. It would then be carefully looking at what other medicines you're wanting to start and making sure that they don't interact with the antiviral medicines that you're wanting to give. But no, do not stop antiviral medicines under any consequence. Over.
Right. Quick question from Raymond. Would you suggest starting antioxidants for COVID positive patients with milder symptoms such as glutathione drips, vitamin C, vitamin E, or even melatonin?
No evidence out there at the moment. So no, we would not be recommending that. Over.
Right. So I'm just quickly checking on the time. This is a really very interesting, as we did kind of anticipate that this is the topic on antimicrobial therapies. So we unfortunately have only 1 hour so that we can also prepare for the next lectures. If you do have questions that were not answered, don't worry. Please review. The slides will be released as a PDF format later this afternoon. And we will also have archive footage on the YouTube. It's the same link, actually, will be disseminated to everyone by email this afternoon. So thank you so much, Drs. Gary Kuyanoshi, Sophie Dennis, and James Effelfinger for giving this morning's lecture on antimicrobial therapy, not for COVID-19 or SARS-CoV-2, we have to emphasize that again, but for co-infections. As we have been discussing throughout the Q&As, we are looking at a solidarity trial currently going on globally for 4 intervention arms. There's more information on the WHO website. Please stay tuned for more information. Vaccines are also being developed, so let's wait for more evidence as it comes along. So thank you so much to all of our, I think we did have 360 plus participants at a certain time during this morning. And we look forward to meeting you again, to having you tomorrow at 10 o'clock a.m. The topic is, Gary, what's the topic for tomorrow?
Oh, you're on mute.
Respiratory failure and acute respiratory distress syndrome.
Right, so respiratory failure and ARDS tomorrow. So until then, have a good morning. Please stay safe and good day.
Okay, thank you all. Thanks, Albert.
Thank you.